everybody hear me okay? Good evening, and welcome to this is actually our second symposium on hip and knee replacement, separating fact from fiction. We're glad that you all took time out of your busy schedule to come here and spend some time with us and hopefully learn a little bit about joint replacement. Part of this seminar, as I mentioned, is going to be hopefully providing some education about joint replacement, understanding some of the common facts, and maybe even dispelling some of the common myths about joint replacement. Another important part of this also is to make sure that you guys have adequate time at the end to answer questions, or to ask questions. You can answer them too if you want to, but to ask questions. And so a lot of this talk will be answering some generalized, proposing some questions, answering some generalized questions about joint replacement, in the hopes that it will stimulate you to ask some additional questions at the end. So we'll have plenty of time to ask questions at the end. This is very informal. If you have a question that you'd like to ask as we're going through this, please raise your hand and we can stop and answer it. I'd like to take just a minute and introduce our panel. It's pretty likely that we will also have some of the other faculty from the Hip and Knee Center at OrthoCarolina joining us, so they may walk in during the presentation and I'll introduce them. It's probably fair to say that as moderator, you always have some additional perks to being the moderator, but I certainly don't want to take advantage of any of those. But I'd like to introduce our expert panel, and I'm not very good at computer graphics, things like that, so I couldn't get the other guys' pictures up to normal size. But I actually was able to do it successfully as I worked on it a little bit more. So we'll spend a little bit of time to introduce the panel. At our far left is Dr. Bo Mason. You guys can figure out which one of them it is. Dr. Bo Mason on the far left, Dr. John Masanis, Dr. Tom McCoy. And, well, I couldn't find a funnier picture of you, so I can put one up there.
Which one is me?
So, collectively, this group has a overwhelming, tremendous experience with joint replacement. Probably not rivaled really anywhere else in the country. So I think it's important that we take advantage of having them here to ask them questions and answer your questions. As with any talk that we give or any information that we provide, it's important to understand that this information is really a generalization, and that every patient recovers from surgery differently, and that sometimes you have to understand that what we say may not necessarily exactly pertain to every single patient, but there certainly are some generalities, some common themes that we hope that you can take away from it. And it's also important to understand that us individually as surgeons tailor things different to our patients based on their recovery. We're going to spend a lot of time tonight talking about arthritis in general. And many of you may not be aware of this, but actually arthritis is the #1 cause of disability in the United States. There are currently about 66 million people in the U.S. living with arthritis, and that's probably a gross underestimation, as there are probably at least another 25 million that have not been diagnosed with arthritis as of yet. And again, many of you know the first baby boomer turned 65 in January of 2011. And so we're seeing a large shift in the population towards patients that are 65 years and older. And these numbers are only going to continue to increase over the next 10 to 15 years. And this is a term that was in a newspaper article several years ago, this term called boomeritis, that basically just describes the baby boomer generation and having to deal with arthritis over the next several years. So if you look at joint replacement surgery just in the United States, and we'll talk a little bit about later some of the numbers at OrthoCarolina, there are about 500,000 knee replacements done in this country currently. and about 300,000, there's a misplaced zero there, but about 300,000 hip replacements. So we are approaching and have actually probably exceeded this year over 1 million joint replacements done just in the United States every single year. And if you look at the projections and you look at the population increase, those numbers are expected to grow substantially over the next 15 to 20 years. 600% increase in knee replacements, 300% increase in hip replacements. And part of the issue that we're dealing with, if you look at this graph and you see the red line that looks at the number or the need for joint replacements going up, the blue line is the number of orthopedic surgeons, or what we call the workforce. And you can see that number stays relatively flat over time. So at some point in time, there's going to be a tremendous amount of joint replacements that need to be done, and yet our workforce is not increasing at the same rate. I just want to take a second and mention something that is extremely important in all areas of medicine. It's particularly important to us here at the OrthoCarolina Hip and Knee Center, and that's the impact that research has on arthritis and on joint replacements. And every physician at the Hip and Knee Center is intimately involved in research, and we have an extremely active research institute. In fact, it's one of the most productive and busiest orthopedic research institutes in the country. And if you just look at some of the numbers, we have 28 FDA-regulated clinical trials that are actively going on right now, over 80 scientific outcome studies that are currently being conducted. The Hip and Knee Center monitors over 6,000 patients with joint replacements every year. So we keep a surveillance on patients that have had joint replacements. Publish over 20 scientific articles per year and present well over 100 meetings per year, both nationally and internationally. And the importance of that is understanding how research impacts our patients, how it advances the science and improves our patient outcomes. So we're gonna start off now just by talking a little bit about arthritis and diving a little bit deeper into it. And I'm gonna ask Dr. McCoy to take us through a little bit about this disease process that we call arthritis. Tom?
Thanks, Brian. I don't have a speaker phone. Can y'all hear me all right? I suspect almost everybody in the audience knows what arthritis is in the ways that matter most. It's pain in the joints, stiffness, and sometimes deformity there. The word arthritis comes from two different words, arthro and itis, and it just means inflammation of the joint. And of the 100 different kinds of arthritis, they all have this in common. A joint is just where two bones come together and move on each other. A bursa is where soft tissue moves on a bone. But arthritis involves inflammation where the two bones come together. And where they come together, they're not supposed to touch each other. They've got this nice layer of cartilage that's slick and shiny and glides better than anything that man's ever made. And what all these 100 kinds of arthritis have in common is that the final common pathway is loss of that cartilage. Now, the cartilage itself is not what's feeling the pain. Matter of fact, it can't even feel pain at all. It's like your hair. You know, you get a haircut and you don't need any Novocaine because there's no feeling there. There's no pain in the cartilage. So those 100 kinds of arthritis, there's two basic categories. One is where the cartilage itself starts breaking down, usually for reasons that are unknown. And those little particles of cartilage get caught in the lining tissue, like getting a speck of dust in your eye, and that causes the inflammation. The other category of arthritis is when you have inflammation that starts on its own as part of a disease process, and that might be gout or rheumatoid arthritis or infection, and that inflammation attacks the cartilage and destroys it. So destroying cartilage can cause inflammation, inflammation can cause cartilage destruction. But when that cartilage is gone, it makes your joint frequently crooked. It leaves that bone exposed, which is kind of rough and scratchy compared to the knee. And that's what all these different kinds of arthritis have in common. Now, the most common cause of the cartilage just going away is osteoarthritis. And you can see all these things, I'd say not so much the cause, but what's associated with it. It's really fundamentally unknown most of the time. This is what's been called the wear and tear arthritis because it happens almost to everybody as you get older, and certainly more common as you get older. But there are also identified genetic factors, and if you have abnormal loading of the joint, like after a fracture or a congenital deformity, it can occur much more rapidly. The other major cause, the inflammatory arthritis, the one that's best known is rheumatoid arthritis. And that's an example of where your immune system gets mixed up and think your cartilage is a germ and attacks it and destroys it. And that's where huge advances have been made, not just in joint replacement, but in medical management. And our friends in rheumatology, which is the specialty that manages the severe medical management of arthritis, can keep that under control for a while, but eventually when the joint goes, it needs replacement. But this is the most common form of the inflammatory arthritis, and it involves 3 million Americans, and it can occur with anyone, even in small children, but it is more common in women than in men. So these are all common symptoms of arthritis. It hurts, it swells, sometimes it actually is stiff, it almost always feels stiff. And as the ligaments get distorted and the cartilage goes away, it can make the bones touch each other in different ways. And at the knee, for instance, that may make you bow-legged or knock-kneed, and that's a secondary effect of the arthritis.
Great. Thank you, Tom. And I'd like to welcome Bill Griffin, Dr. Bill Griffin, to the panel.
I apologize for being late.
I think it was pretty obvious what picture he was.
Did I miss something embarrassing?
It was all good, Bill.
Yeah, all good, I'm sure.
Well, so Dr. McCoy has given us a nice overview of exactly what arthritis is. Can you talk to us a little bit about how you make the diagnosis, and then a little bit about what do we see on an x-ray when we look at it?
Absolutely, Brian, and thank you everybody for coming. And let me just ask the audience, how many people have had joint replacements here already? Okay, good number.
Might get you up here to teach.
All right, so in the office, and those of you who've had a joint replacement, and a lot of you that have seen us already, you know, when you come to the office, we just don't take an x-ray and come in and say, well, you have arthritis, you need a joint replacement. A lot of this is by history. We sit down and talk to you. That tells us so much. Talk about how your pain is, when it happens, is it activity related? A lot of questions like that that help us to determine, number one, if you have arthritis, and number two, is your arthritis bad enough to do anything about? So we always take a very careful history when you come into the office. And on examination, we look at the obvious that Dr. McCoy mentioned earlier, swelling in the joint, deformity in the joint, stiffness in the joint. And then if we think you have some type of inflammatory component to your arthritis, there are a lot of blood tests we can do in that regard. You know, things like rheumatoid arthritis that Dr. McCoy mentioned earlier, when your cartilage is recognized as a foreign substance, your body forms antibodies to attack that cartilage. And you can look at antibodies in the blood and see if you have it. It's called rheumatoid factor. And there are a lot of other things we look at to look at inflammation in the body. And then we can also take fluid out of the joint and have it analyzed. Do you have gout? Are there crystals in your fluid? You know, gout is when your blood forms crystals and it deposits it in joints. And we can take fluid out and see if you have gouty arthritis. And that treatment may be completely different than something like a septic arthritis from infection or rheumatoid arthritis. So we have to be very careful in that we diagnose what type of arthritis you have, because treatments are very different.
So you would agree that obviously the most important thing that we do when patients come in is we talk to them, we get a history, we examine their knee, and then x-rays would be the next most important tool for us.
Absolutely.
So
Absolutely.
let's go through a knee, and then we'll look at a hip, and just give us an idea of what you're looking at when you look at these two x-rays when you see a patient knee.
All right, so this is very important. On your left, you're going to see a normal knee x-ray, and what you're looking at you're looking at the upper bone, the femur. The lower bone is the tibia. And we look at several things. One thing we look at is we look at the space that you see in between. This is the outside of the knee, this is the inside. The outside has this little extra bone over here. That's how we determine the outside from the inside. And we look at this space. The space is not just an empty space. That space is cartilage. Cartilage does not show up on an x-ray. So we look at that space, and what you want to do is you want to see a nice healthy space, and you want to see an equal space on the inside and on the outside. And that's what we see there. Now when you develop arthritis, no matter what type it is, and you start having loss of cartilage, as Dr. McCoy mentioned earlier, your bones, they move closer together. And if you look at the x-ray on your right, here's the outside of the knee, there's that extra bone, and you can still see a cartilage space there. But look at the inside. You've not only lost the cartilage, but the bones are rubbing against bone and actually wearing out the bone. You see how flat this bone is over here? This one's angling down now. So that upper bone is wearing out the lower bone. So what happens when you preserve one side of the joint and the other side collapses down, you develop a deformity. In this situation, this person is severely bow-legged. We call it varus. It's bow-legged because the bones are closer together and you can see. Instead of being slightly knock-kneed like most of us are built, this patient is severely knock-kneed. And so that's what we look at. And then if we look at the hip, which is the, I'm sorry.
I don't think we have a picture.
We did.
Do we?
Lost it somehow.
Okay. It's the same thing on the hip. The hip's a little different joint. The hip is a ball and socket joint. And when you see the ball in a socket, and it's just exactly how it sounds, a socket with a ball inside, and there's a big space all the way through that ball and socket joint, and that space is cartilage. And as you develop arthritis, that ball and socket move closer together. And most of the time when people come in, they're hurting enough to see us, their ball is actually rubbing on their socket. And that's just another telltale sign that we need to talk to them and see how severe their arthritis is to see if they would do well with the joint replacement.
Thank you. So, since Dr. Sheff's not here yet, Bo, do you want to talk a little bit about patients in your office, diagnose them with arthritis, and so many times we see patients and they think, oh, my only option is I have to have a joint replacement. Talk a little bit about what some of the options are for these patients.
I think there are a number of different things that we look at. I mean, you don't want to think that the only option that you have when you end up coming in for an appointment about an achy knee or an achy hip is that you have to have surgery. And we try to carefully outline what options are available. Some people do come in, like that x-ray that was on the right just a minute ago, in which that is end-stage osteoarthritis of the knee, and there really are no other good things that we're going to be able to offer that person. Surgery is going to be the best way to get them back and up and moving. But before you get there, you want to make sure that you've done things to take care of your knee. You want to exercise. Because often the motion gives health back to the cartilage, and getting the strength of the muscles around the joint can protect the cartilage that still remains. So exercise is always an important component to trying to salvage or maintain a joint. Sometimes anti-inflammatories can help calm down that inflammation. Dr. McCoy talked about the speck in your eye and the inflammation that's there. This would be sort of like drops that help lavage that your eye. You want to also look at the possibility of some injections. Sometimes injections into the knee can cause or can soothe the pain. There are two types of those. One's an anti-inflammatory, which is a cortisone. The other is a type of pseudo lubrication that we can use to put inside there, and those can give relief. We talked about some of the other things. Weight loss is very important. We know that weight is associated with the development of arthritis, at least in the knee and probably in the hip as well. So taken into account, we still want to steer people away from surgery until you get to the point where that pain is life limiting.
One of the questions we commonly get, though, is about. I'm sorry. Question.
Efficacy of injection.
Okay.
if you're using an anti-inflammatory like cortisone and the patient, is able to utilize that, how long, what's the longest period that it would work for someone?
Well, you can get what's called rheostasis or reestablishing of the normal environment within the knee by cutting down on the inflammation. And if you can reestablish that, then the joint may do well for a long, long, long time, years in fact. And some people come in and claim that I had one shot, it lasted for 6 years. Well, the shot didn't last for 6 years, but the effect did. The effect in terms of turning off the inflammation is really pretty short term. But you can see patients that'll get a week, 2 days, or 4 months worth of improvement from an injection into a joint.
Is there another?
Yes. So an injection, it doesn't actually cure it, it doesn't rebuild the cartilage, it just manages the pain.
I wish it did, but as of right now, no. It's helping you manage the inflammatory component of the arthritis.
So your condition it doesn't go away.
But your condition doesn't go away, but it may allow you to reestablish some of the strength around, the motion. The cartilage itself doesn't have a blood supply, much like it doesn't have a nerve supply. So it gets its nutrition from actually an exchange, kind of like a sponge that you push and allows it to drink the fluid back up, which is the synovial fluid. That has the nutrients for the cartilage cells to be able to live. So that it's like respiration for the cartilage getting exercise. So if you can get back into a situation where you can exercise the joint, that's what we're trying to drive towards is a more normal environment for that joint.
There are a lot of medical conditions that you can't cure, but you do better managing. For instance, if you have diabetes and you need insulin, you're going to do better if you take your insulin, but the insulin's not curing it, but it helps you live a more normal life and not develop as many secondary problems. The same is true for the arthritis. Sometimes people say, well, if I have this process, I don't want to cover it up. But in fact, really the right thing to do is to cover it up so that you can get exercise, enjoy life, and do the things that you need to do and want to do. Because it's not like covering up cancer where you're blowing your chance for a cure. The wonderful thing about the arthritis treatment, the ultimate treatment, the joint replacement, is the timing's not critical. So it's not just having the joint be worn out. It's not just being sure that more conservative things aren't letting you get the same result. It's picking the time that's right for you, and everybody's individually different there, different risk tolerances, different fears of surgery, different things going on in their life. And so a lot of this is picking the time and having the freedom to pick that time.
There's also all degrees of arthritis, where somebody may have very mild arthritis but happens to have had a busy weekend and has a tremendous flare-up where the knee swells up and they're just as miserable as somebody who has severe arthritis. In that case, cortisone shot is very effective and gets them back to fairly normal function. Somebody with an x-ray like we saw earlier that has end-stage arthritis, the injection is quite variable, and that's where it may only help like 2 days, as Bo mentioned, or we have patients, we all have patients that come in every 3 months for an injection with terrible-looking knees and may not be able to have surgery for other reasons, and they do reasonably well with just ongoing injections.
Is there I had seen 3 different doctors before I decided to do the surgery. And they told me that I was fairly young to do the surgery and that I would probably have to have another replacement in 10 to 15 years. Is that necessarily the case? Is it depend on the person, or is that?
Quite variable.
Yeah.
Who wants to talk to that one?
There's a paper that's getting ready to come out of New York that looked at their patients under the age of 55 that had knee replacements. And they looked at them previously at 15 years, and now they're looking at them again at 25 years. Not all the patients.
Can you talk a little bit louder?
Yes, ma'am. Not all those patients are still alive, unfortunately. But of the ones that they're able to see, more than 75% of those patients at 25 years are still functioning well with their implants. Now that's 25-year-old technology. So we don't have, we would suggest that some of what we have now is better than what they were using back then.
Just touch on the area why I have the slide up. The supplement industry is a multi-million, maybe even billion-dollar industry without a whole lot of data behind it. Can you kind of give us your thoughts on the pros and cons about supplements?
Glucosamine, chondroitin sulfate, there are a number of studies that have been done that are government-sponsored studies, one that was published in Lancet, one that was sponsored by the NIH, that have looked at those as supplements. The reviews have been relatively mixed. Some patients have found that they reduced the sort of the stiffness associated with arthritis. In no case do any of these supplements rebuild the cartilage. So they are costly. If you try them and they're not working for you in a month or two, there's no reason to continue taking them. But some people do in fact find that they are.
There's also a lot of snake oil out there too. And arthritis is very prone to snake oil because arthritis has peaks and valleys, flares, and when you feel good. And if you happen to take shark cartilage when you're in one of your flare-ups, and all of a sudden you get better, you're going to swear to your neighbor that that shark cartilage made your arthritis a lot better. So we've been through probably a dozen different fads of different things people have used for arthritis. DMSO, shark cartilage, I don't know, there's a bunch of them. But
Magnets.
Raisin soaked in gin, that's a good one. That one really works.
It works better if you leave the raisins out.
Yeah.
I think the important thing is most of these popular over-the-counter ones are not dangerous. And remember, the goal of non-operative treatment is to feel better. And so if you feel better, the side effects of the snake oil a lot of times is a lot less severe than of the medication. So don't feel bad about taking an over-the-counter one if it works for you, because what you're trying to do is feel better, and you're the expert there whether you feel better or not.
Let me just give you some advice if you do want to take one of these supplements, and it's probably okay to do. Be sure you're taking the right supplement, and be sure you're getting the right medicine for the right price. A lot of these supplements combine a lot of other things you don't need, and they charge you a tremendous amount, over $1, $2, or $3 a pill. If you're taking 2 or 3 or 4 pills a day, that really adds up. Consumer Report, periodically, at least once every 2 years, will give a review of the supplements, and they'll just tell you how much medicine is in the supplement and how much it costs. And some of these supplements like glucosamine, chondroitin sulfate, you get at your GNC or one of your health stores, and they're going to charge you $2 a pill, whereas Costco and Walmart that give you more medicine are 25 cents a pill. So be careful that you don't deplete your funds trying to do the supplements, because there are a lot of good supplements out there that are very inexpensive, and Consumer Report does a very good job on that.
It's online.
I heard at one time the only side effect of supplements is that it makes your wallet lighter.
One caveat: it can increase if you've got a high cholesterol. Some of those supplements, you don't really want to know what they're derived from, but some of them are derived from animal products, and they can increase your.
It's like eating gristle from a steak.
Yeah.
Now, in general, I would say it's regulated by the FDA, but as a food product, not as medicine, so it's not subject to as much scrutiny. But one of my friends who's a prostate cancer physician told me that there's been a recent study associating chondroitin with increased risk of prostate cancer. So, in general, they're safe, but that one may not be for me.
Well, another one that used to be used, the DMSO, is an industrial solvent they used to use for horses. And so people started using it. You can rub it on your joints. And it's a solvent, you can stick your finger in it and you can taste it as soon as you put your finger in it. And it was associated with cataracts. It could form cataracts. So there are some that have side effects.
I'm here on behalf of my mom, but I just had a question. So when the cartilage is damaged and it's gone, I mean, there's no way to rebuild it. There's no way for it to come back. There's no way to reverse the effects.
There's,
John, you want to take that?
yeah, tired of hearing you guys talk. No, the problem is, Dr. Mason pointed out, is the cartilage does not have a rich vascular supply for healing. So like other tissues of your body, when they're injured, they tend to respond by a healing process and rebuilding process. Articular cartilage is one of the substances or products that your body makes that is very hard to regrow. And we've failed pretty miserably, even in the laboratory for the last 3 decades, trying to simulate and regrow articular cartilage. In the last 15 years, we've been able to do that and actually harvest cartilage from a joint, grow it in the lab, and then reinsert it back into the joint. The problem then becomes a mechanical issue. How do you reattach it to the bone surface? And how does it stay in place when it's undergoing the wear and tear of your normal joint motion? For that reason, small cartilage defects, so roughly the size of a nickel, that are contained by normal cartilage or surrounded by normal cartilage, they have been successfully repaired through 2 or 3 different techniques that we use to either regrow cartilage or transplant cartilage. But when the defect is what we call uncontained, I'll use an analogy. If you have a pothole that's on the side of the road that doesn't have normal pavement around it, it's very hard to patch that and have it succeed. It usually tends to disintegrate quickly over time. And that's what happens when the cartilage erosion becomes too large in the joint. And so for those reasons, we've not been very successful at trying to patch and repair cartilage defects for the adherence problems.
So, Dr. Sanas, along those same lines then, the question is, when is it then time for me as a patient to consider having a joint replacement?
So as Dr. Springer pointed out, roughly 1 million people in the United States will have this question posed this year. And it's one of the things that we spend time in the office talking about pretty frequently. Because people who know they have an arthritis diagnosis, they've tried conservative measures that have not succeeded. And then they frequently ask one of the surgeons, well, is it time? Am I ready for my joint replacement? And the answer to that question brings up sort of 2 common themes that we talk about. One is quality of life, and the other one is an individual decision. And those 2 issues should really be the driving force for the answer to that question. So everyone has different expectations and requirements in their daily life. For some people who are more sedentary and do not have a high activity level, they can tolerate a certain degree of arthritis and immobility and really not have much of a change in their quality of life. By the same token, somebody who's very active on their feet or enjoys some type of athletic sport becomes more cumbersome for them. Their quality of life seems to suffer more greatly when they develop arthritis. So it's an individual decision, and what we use is, in my office, a common conversation that I have is a couple kind of red flags. One, are you losing sleep at night? Are you not sleeping? We all know that once arthritis becomes painful in the evening and you're not able to rest, that has implications on your overall health. Number 2, do the bad days outnumber the good days? So, or more often than not, are you limiting what you can do activity-wise because of your arthritis? The third one, are you requiring pain medications on a regular basis to handle the arthritis discomfort? And that can be in the form of an anti-inflammatory if you're taking it and requiring excessive doses of it, even more than what's prescribed, or if you're requiring a narcotic for pain relief, because we know that's not a good long-term plan because your body develops a degree of tolerance of narcotics and you require more over time. So when someone starts answering yes to those questions, then I tell them I think it's a reasonable time to start considering a joint replacement. The biggest thing with regards to joint replacement is to make sure that you've failed the conservative treatments, activity modifications, weight loss, injections, those types of things which can buy you time and hopefully put off joint replacement. Ultimately, when you make the decision about joint replacement, your satisfaction with the surgery has a great deal to do with how severe your arthritis was pre-surgery. So if you have significant disability from your arthritis and your arthritis is severe, you tend to be more satisfied with your outcome from joint replacement. If you have less severe restrictions from the arthritis and your expectation is this surgery is going to give me my knee the way it was when I was 16 years old, you'll probably be disappointed. We have an adage in orthopedic surgery that says it makes bad problems better, but it doesn't make things normal. All right, so there's always some limitations after joint replacement surgery, be it hip, knee, or shoulder, that make the joint not function as well as your God-given native joint. So we just have to keep that in the back of our mind.
And I think, as you see here on the top of the slide, the old adage for joint replacement historically was wait absolutely as long as you can before you have surgery. And I think that has changed a bit over time. One is what Dr. Mason said earlier, we're more confident in the materials that we use, that they're more durable, that they're going to last longer, so we expand our indications to a younger age group. But secondly, if you look at functional recovery, I mean, joint replacement surgery is such a lifestyle surgery. It's not a quote, bionic joint to allow you to do things that you could never do before, but to allow you to get back to the lifestyle that you had before you suffered from arthritis. And so if your goals after surgery are to be here from a functional standpoint, and now you're here, you have about this much of a gap to make up. But if you wait absolutely until the bitter end, and now you're all the way down here, you have this much of a gap to make up. And most of the studies would suggest that maybe you can't get back to that level that you want to. You may be able to get back to where you were 5 years ago or 10 years ago. So I think that thought process has changed as we start to see more rapid recoveries in patients, better materials, et cetera. Question?
This may be a little off topic, but given the current political climate and changing healthcare laws, my decision to have my joints replaced is going to be based on that as well as my health. I just wondered if any of y'all had
Bill, why don't you tackle that?
opinion or comment?
Well, I think not just the Obamacare implications, but the economy in general has influenced patients' thinking over the last couple of years. We've seen a lot of that in the office. And so when you make a decision whether it's time to have your joint replaced, it's a very fuzzy endpoint as to when is the right time. And a lot of factors go into that decision. When is it right for your family? If you're a teacher, when do you have school breaks? And if you're worried about losing your job next year, when are you going to have insurance or not have insurance? Those kind of things. Our goal is to try and rule out all the extraneous factors and make a medical decision for you, but there's no question that some of those economic factors come into play. So you'd hate to say you need to put it off another 6 months and then have it a month after you lose your insurance or something like that. I don't think there's going to be any cataclysmic Obamacare event in the next year or two that's going to deny joint replacement to anybody over 50. I don't think that kind of thing is going to happen. But there certainly are other factors, economic factors that come into play in the decision making.
Sir, Matt?
Overall, which particular joint replacement would you say you have the most success with long term?
Well, I think that kind of goes nicely into our next question a little bit. Maybe you can tailor that onto your discussion. But let's talk a little bit about exactly how joint replacements work, specifically looking at that.
Yeah, we can just talk about the parts in general. We'll talk about both hips and knees, and that's primarily what we do. There's a lot of joint replacements out there, from knuckles to shoulders, elbows, ankles, but most of what is done around the country and most of what we do is hip and knee replacements. And your question in particular, when people have a hip replacement, oftentimes a year or two later, they can forget which hip it was. They get back to fairly normal activity and can have very good function of their hip. With knee replacements, they're good operations, but they're not quite as 100% as a hip replacement. People generally are always aware of which knee was replaced and maybe even have a little bit of achiness or stiffness with the knee. So a knee replacement is a good operation, but not quite the home run that a hip replacement generally is. Did you have another question?
Yeah, one follow-up to that. If you have arthritic condition, both hips, you know eventually they're going to have to both be done. Would it make sense to do them, delay one and do them both at the same time? What do you feel about that?
Well, there's if they're both equally bad and terribly debilitating, that's potential rationale. However, there's increased risk doing them both under the same anesthesia, same day. Blood loss, it's a little tough on your lungs. So there's some other risk factors that come into play where with hips, we rarely do hips on the same day. With knees, there still is a risk factor, but it's a little more commonplace to do 2 knees in one day.
But I think the answer is, do you do one prophylactically for financial or convenience reasons, is a pretty resounding no. And the reason is that even though the success can and usually is very good, there are always the possibility of severe complications. So you really don't want to do it just on the likelihood even that you might need it later. It's really based on how bad that joint is right now.
Question here?
Yeah, I got you. My husband's gonna have to have hip surgery, but his knee now is bothering him. Can you explain why that sometimes happens?
Well, knee pain can either come from a bad knee, or it can come from a bad hip, or it can come from a bad back. So sometimes when you have knee pain, it's not necessarily the knee. So if you know he has a bad hip, there's a good chance that that knee pain may be coming from the hip. So that's where part of what we do in the office is sorting out if a lot of people, not a lot, but we have patients that come in thinking they've got a terrible knee when it's actually a bad hip. So that may be the case here.
Bill, talk a little bit about these x-rays.
Okay.
And what we're looking at.
So we talked about what arthritis looks like when you lose the cartilage and you have bone rubbed against bone. And with the hip replacement, we're somewhat trying to recreate a normal ball and socket joint. And we basically throw away the damaged ball. We cut across right here and throw this away. And then we put in a socket, a metal socket, and a stem that goes down in the bone that helps support the ball and recreate a ball and socket joint. So it restores full range of motion. There's no bone scraping on bone, so it gets rid of the pain. And then in the hip, we use surfaces on the metal that have a rough porous surface, and the bone actually grows into the metal and attaches directly to the metal. So we don't have to glue or cement the parts to the bone. And same thing on the femoral stem side. We use rough porous surface that the bone actually grows into the parts. So over the last 20 years, we've become very successful at getting these parts to attach to the bone. And the weak link in the system is the bearing surface, where the ball rubs against the socket. And there's several different bearing options: metal heads on plastic, metal heads on metal, ceramic on ceramic. So there's a lot of bearing options, all of which have pluses and minuses. But probably the consensus at this table would be either a metal head or ceramic head on the newer plastics that are designed to resist wear, and have actually have had very good results over the past 10 years with the newer plastics. 90% less wear than what we had 10 years ago. So that's pretty much how a hip works. The knee is a little more complex. It's basically a hinge joint, but it's kind of a complex hinge joint. And we try to recreate that knee to be as close to normal as possible, but it's still somewhat of a machine that works like a hinge. And a lot of people think that when you do a knee replacement, you just whack it here and take the whole knee out, but it's really more of a resurfacing of the damaged bone. So we just remove the surface and cap it with a metal thermal component. We remove the surface on the top of the tibia and put a tray on there. And then you've got a polyethylene insert, kind of like a brake pad in between the two metal components. And then it works like a hinge that also allows a little bit of rotation.
Do you also do the osseous integrated hip inserts?
So on the knee, we can put them in with or without cement. In the 80s, there was a strong push towards cementless total knees, and the success rate was not nearly as good. They can work, but they have a higher failure rate. They tend to loosen earlier or never become fixed to the bone. So I would say that 98% of the knees put in are put in with cement to attach them to the bone. And the loosening of knees is generally not the problem. It's generally a wear issue, just like the bearing surface in a hip. So cement has worked very well. There's some new materials coming out that may make cementless knees more predictable, and that may grow in use over the next several years.
I was thinking in terms of the hip procedure as opposed to doing the whole ball and socket replacement.
So you
you're talking about a
referring to
resurfacing?
resurfacing procedure?
Yeah, with osseous integrated
Well,
segments.
there are procedures where you don't use the whole stem. You save most of the ball and you just put a cap on the ball, and it is a larger ball and socket. And that's very attractive to patients. It seems like a lesser procedure, saving bone for the future. So it has a lot of good appeal. Unfortunately, it doesn't work as well. So the downside is that they, in general, they have twice the failure rate in half the time. So what seems like a good idea has not worked great. There are certain patients that do better with it than others. 80-year-old little old ladies tend to break the bone if you don't replace the neck. 50-year-old men with strong bone tend to do better. So there are certain pockets of patients that it may be appropriate, but overall, it has a higher failure rate in less time.
So I think this is a good segue, Dr. Mason, into this portion of it. And I'll preface your question, which is, as a patient, should I be able to choose the type of joint replacement that I want? And I think we're in a very interesting time right now with the internet age, with the way that information is rapidly disseminated, both good and bad. And so we see this whole phenomenon of companies advertising directly to patients. Mary Lou Retton's knee, Jack Nicklaus's hip, etc., Jimmy Connor's hip, etc. And this information pushed directly to patients. And if you go on the internet and you type in joint replacement, at last check, you almost got 11 million hits or websites that you could go on to look at joint replacement. And it's very hard for you as a patient to disseminate through a lot of that information. And technology is rapidly advancing, which is good in a sense, but can also be dangerous in a sense. And many of you who probably read the newspaper or watch TV have seen ads on TV about recalls from companies about early failures of hip replacement. So I'm going to kind of ask Dr. Mason to comment about whether or not patients and what discussion we have with patients about choosing implants.
Yeah,
And
I think, Brian, it's a great topic, and it's one we spend a fair amount of time in the office. I don't know anybody that wouldn't want to be able to pick what they perceive as best for them. I mean, we pick our cars, we pick a lot of different things in life, we pick our golf clubs, and, yes, ma'am, I'm sorry. We pick a lot of different things that are meaningful for us. So you say, okay, well, I'm going to do my research, and I'm going to pick out what type of hip replacement or what type of knee replacement is best. And does that appeal to everybody? I mean, who's got the hip? The people that have joint replacements, raise your hands again. Joint replacement. Did you pick the joint replacement? Anybody pick the joint replacement they put in there? You picked the joint replacement you put in there. Of those, do you think that the fact that you were able to pick it made a difference in terms of how well you did? And I would suggest to you that the answer to that is no, and it's because the surgeon knows the answer to that question probably better than you do. It's great to have the information. It opens a discussion. There's no reason not to do the research. It makes you more informed, makes you more aware, makes you more able to understand what's getting ready to take place. But I don't think that necessarily it's the right place. You can make a suggestion, you can have a discussion, but I think ultimately your surgeon's going to understand the answer to that question better than you do.
I'm sorry, do you guys get, do you specialize in certain hips, knees, in the brand, whether it's a DePuy knee or if it's a Right Medical hip or?
I think we all figure out how to use implants best. I mean, if I use a particular type over and over and over and over again, I understand all the nuances associated with using that type of an implant. And each one of us do that. We all have experience using essentially every implant that's out on a major implant that's on the markets, but we've settled on what works best for us. And that's based on our study, that's based on research that we've done, research that others have done, and our comfort level, and a lot of times some of our training in the past.
But the other thing, the hip and knee replacements that we use are all a slight variation of the same theme. But what's very important for us also is the instrumentation we use to put them in. The way we measure the bone cuts, the way we do it, the broaches or the saw, the guides, they're all very different. And if you're comfortable with using the same guides, the same tools every time, then you're going to do a better job. And I suspect that if somebody comes in and asks me, well, I want this particular joint, it's up to us to explain why that may not be the best decision for that patient. For instance, you know, direct-to-consumer marketing is out there, and it's just, I know it's just inundating you, and you just wouldn't believe how that changes our practice.
It's democratized the conversation, and I think that's a good thing. But, you know, if you look at where these joints potentially fail, or what the risk is not so much that the implant is going to fail. The risk is that it's not going to potentially be put in correctly. And we know with a number of studies that you're much safer having a surgery done by a hospital that does a high volume of joint replacements and by a surgeon that does a high volume of joint replacements. So those metrics match, and they match in your favor, and that's why you want to find somebody that does a lot of a particular type of an operation.
So do you guys, just another question on that, I mean, because I think she's getting a DePuy knee, and I have some friends in New York that work with Wright Medical and DJO, and are there variations of a knee implant that you guys work with, and if there's a new one that's coming out, will you disclose to the patient, hey, we're using a new implant or a different implant to let them know, and you're the 10th person that I'm gonna put it in, or how does that work?
Somebody else want to take that?
I'll take it on.
great
I mean, I
question.
think that's a great question because ultimately, with evolution of new products, there's going to come those times. And so I think the role of your surgeon is to do a few things. Number one is to try to weed through what is fact and what is fiction for you. So based on their experience, you certainly kind of two caveats. You don't necessarily want to have the joint replacement that's never been put in before, that's
Right.
brand new and looks great on paper, but really has no track record. By the same token, something that may be archaic 25 years ago that functioned pretty well might have inferior properties to some of the materials that are now applicable. So there's a melding of those two, and you need to find something that has some early stable track record with some proven design characteristics in the past. One thing that we have learned about joint replacement over the years is that you need to make changes relatively slowly, and they should be small. And so if you change multiple aspects about a joint replacement, frequently in our history, we've gotten into trouble.
Evolution over revolution.
Exactly. So it needs to be somewhat, Darwinian like that, and that over time, the better products tend to show themselves. And so it's important, and some of you may be candidates for a certain type of implant that may be newer. It may be part of an FDA study. Brian mentioned that we have those. And so if there is something that's been approved via the FDA, it has basic science and laboratory work behind it, and it's had some preliminary studies. We may bring it up and say, here, this has a potential to be a better implant for X reason. We're following it. And if your surgeon thinks it's something that has merit, they may ask you to participate in that study. You certainly have the option to decline and say, no, give me what you were putting in 2 years ago or 3 years ago. So I think that's very reasonable. The other thing when you said, I've only put in, you'll be the 5th person to have this implant. If you lined up all the, let's say, knee replacements from 6 major manufacturers here on this table, you'd have a hard time figuring out what the differences are between them. As Dr. Beaver pointed out, the concepts are very similar, and so the changes and differences are quite small.
But just to mention one other thing, Dr. Springer at the very first mentioned our research institute. And we do that for a number of reasons, but one of the biggest reasons is we want to make the world a better place. And the way to do that is to follow our patients with the technology we have and how we put them in to see how they're doing. If you don't follow them, if you don't read history, you're going to repeat it. So we look at history, we look at our patients, we see how they're doing, and we also are putting these joints in very frequently, and we know what problems these joints may have. We may not like a certain characteristic, and we're very fortunate. We work with the implant companies to help design the newer implants. So we're working with the engineers, we're working with these companies to make implants better. We're tweaking them all the time, because if you don't put them in and you don't follow patients, you'll never know what problems you can make better. So that's a great thing for us. We really all enjoy doing it. and our patients enjoy being involved in the research.
We have to be very careful about innovation, however. Any new thing that comes out always has a good story that goes with it. And when you look at it in retrospect, even the ones that went bad had a good story. And when we have an operation that has a great success rate, like 98% success at 10 years, you want to make sure that you don't do something new that drops it down to 90% success. So it's hard to improve on 98% success, and usually it is these minor evolutionary changes.
So Dr. Beaver, talk a little bit about, it's interesting fact, 70% of joint replacements done in this country are done by surgeons that do less than 25 a year. And speak a little bit about, both touched on this earlier, but just about volume and how that relates to clinical outcomes.
Sure. I used to use the analogy about my golf game. The more you play, the better you get. But I had, let's pick another one. Golf's not a good analogy at all. But it's the things you do every day, the repetitive nature of what you do. And if you do something over and over again, and the results aren't doing well, you're going to change the way you do it. And if you don't do it enough, you're never going to know the mistakes you make. And so we specialize just in joint replacements. That's all we do, joint replacements. And unfortunately, like Dr. Springer mentioned, most of the surgeons that are putting these implants in, 60% of the joint replacements that are put in this country are done by people that do less than 10 a year. And we do, on average, probably 10 a week per surgeon. And so we have the expertise to do it. We've all had special training to do this, and we specialize in it. We don't do feet one day and hands the next. This is what we do, hip and knee replacements. In our joint center, we do about 3,000 joint replacements a year. We do 700 revisions a year, a redo, for a lot of different reasons.
Not our own.
Not our own. Very much. Thank you. Dr. Griffin gave a talk at Duke one time talking about the infections and the surgeries we're doing for infections and what high volume infection problem we have. And the head of the Duke program said, "Why are you guys getting so many infections?" Dr. Griffin had to say they're not ours, but we're a center where they send these problems to us.
We're at the bottom of the funnel.
We're at the bottom of the funnel. We get people from all over the country that have problems with their joint replacements. They come here because we specialize in it. And if you do enough volume, you're very comfortable in redoing these joints the right way. So we have protocols for our patients. We have procedures for our patients. We have standardized protocols that we follow. We do a lot of teaching around the country on how to do this. We even teach orthopedic surgeons how to do it. They come and spend an extra year with us, coming into surgery, assisting us, not doing our surgeries, but assisting us. And we're training that next generation surgeon to go out and help with a very, very common problem. Like Dr. Springer mentioned, we're doing about 1 million hip and knee replacements a year. Well, that number in the next 10 to 15 years is going up to 3 or 4 million. Well, that also equates to us. We're doing probably 700 or 800 redos here a year. Well, that's going to double or triple with the number of primary joints that are done. So we have to prepare the next generation to do that. And we enjoy teaching, we enjoy lecturing, we enjoy implant design work, and it's all a big cycle. I mean, it really is a very enjoyable thing for us.
I have a question about the muscles and the tendons. How do you deal with them? Which ones are cut totally, and are there any that aren't cut? I mean, I know you have to move in there with the blades and everything else, but would you address that?
Dr. Saunders,
Sure.
address that question?
And do you have a specific topic as far as hip or knee, or the general question? As far as knee? Sure. The main issue that comes up, we're talking a lot about replacement of the cartilage on the end of the bone, but there is an envelope of soft tissue, including muscle, tendon, and skin, surrounding those joints. And so access in and out of the joint is important, and it's an integral part of the surgery. It affects how you recover, and it can affect your success rate. There are a number of different techniques to access the knee joint, essentially to get what we call exposure of the knee so that you can do the surgery accurately and do it well. The exposure techniques, there's about 6 different ones used for a first-time knee replacement. And our literature reproducibly shows that 12 weeks after the surgery, there is no difference between any one of those techniques. So if we make the incision smaller, or if we go under a muscle as opposed to through a portion of the tendon and repair it, all those things are very short-term, have very short-term effect, if any. So some of them have very small effects at about the 4-week mark, but 12 weeks after the surgery, your recovery should be identical regardless of the surgical approach used to perform your knee replacement. Okay?
I understand that's why the machine is so important, because you're stretching out those tendons that were put back together again.
The continuous passive motion machine, or what's called a CPM, you've seen them or heard about them. They're frequently used after knee replacement, and knee replacement different than hip in the fact that the knee is unique, I guess, along with the shoulder, and that it's one of the joint replacements that we do that we say, great, you've had your joint replaced, and we know it's sore, but now you need to move it right away. And if you don't, you're going to get stiff, and you may never get adequate motion back to really enjoy the joint replacement that you've had. So that's what makes knee recovery more difficult than hip recovery, is that we really emphasize motion right away. The motion machine, from a research standpoint and technical standpoint, is equal to, or I should say not superior to, a good therapist. So more importantly, you need to have good pain control and good therapy. And you could do without the CPM machine, the motion machine, if you had those two things. Most people like the CPM machine. They tend to, it's a little less traumatic for them, and they enjoy the motion is somewhat comfortable for them. So there's no downside to using it. But I would tell you the most important things about this: having the surgery done well, having your pain controlled, and having good therapy.
Yeah, just a
How do you
comment.
see that after 12 weeks, because they wouldn't show up on an X-ray?
Excuse me?
You're saying after 12 weeks that the surgeries have been successful as far as the muscles and tendons?
Yeah, that's not on X-ray, that would be on physical
Right,
exam.
on your exam. So,
Range of motion,
correct.
range scores, things like that.
Okay.
right.
Tom?
Go ahead.
Okay. Question?
I do have to have both of my knees replaced, and are there any benefits to replace both knees at the same time? And what would be the downfall, if there is any downfall?
Great question. Who wants to, Tom, you want to field that question?
The most obvious advantage of getting them done at the same time is it takes as long to recover from 2 as it does to recover from 1, so it saves you time. The downside is that it's more dangerous. Now, there are some occasions where you really need to do both at the same time, and that's usually if you have so much deformity or crookedness to your knee that you really can't walk without straightening them both out at the same time. If you're healthy and the risks of doing 2 are very similar to doing 1 twice. The risk of a serious complication to your lung or your heart does go up markedly as you get older, and it's the real place where that curve changes is around 75 years old, and so in general it's discouraged for people who are older, and it's an option for people who are younger who, again, not doing 1 prophylactically, but that they both hurt about the same amount.
And what is the normal recovery period as far as to have your knees replaced?
You know, that's really where, depending on where you call yourself recovered. Most people who've had their knee done, who are real happy with their knee, say it continued to improve for 9 months to a year. At the same time, you're functioning at a much higher level before then. For instance, most manual laborers are back to work within 3 months, and clerical work and retail work, say, usually in 6 weeks, and self-employed are usually back at work in some capacity within a couple of weeks. A lot of the soreness and puffiness is gone by 3 to 4 months.
So just this may help you, we'll go down the panel, let's just say we each average roughly 200 joint replacements a year. Knee replacements, not hips. Of those 200, how many patients would you have in a year that you would do both their knees at the same time? Bill?
1, maybe 2.
1.
Tom?
30, 40.
Okay.
5.
Bill?
Probably about 20.
And I'm probably about 5.
When
So, I'm
y'all
sorry?
did the toe
Phil, why don't you,
Yeah,
touch on that, maybe John, you can.
We've done a lot of work in that field. We were one of the first centers, in fact, Dr. Griffin and I and one other, Dr. Faring, who's not here, were involved in some of the very initial development of those machines. And we spent a long time, a lot of knees. I think I did close to 600, 700 knees with computer-assisted navigation. Learn a lot in terms of what my various characteristics of surgery are. But when we started studying what the outcome was for those patients, weren't able to demonstrate any tangible improvement. When we look at that, and that's a prospective randomized study in my hands, when you look at that across a very broad range of surgeons, indeed we did see that you're able to reduce some of the outliers. So when we looked at another study, we looked at all of the published reports that are out there. We know that they work. We know that they help improve the alignment. But in terms of how it improves the individual patient outcome, we haven't been able to show that yet.
So it may be better for physicians who maybe don't do a lot of knees, and it gives them guardrails to keep it within a certain range. If you do more of them, it may not have quite the benefit.
But the other thing is, sometimes the computer-assisted surgery works well if you have significant deformity,
Yeah, that's true.
and you can't use more traditional alignment tools in surgery, or if you have hardware that's in the leg and it blocks you from using more traditional instrumentation, then I think the computer works very well for that.
I think it's a useful tool that is not a detriment. Certainly can assist some surgeons, and in some scenarios more so than others.
So I think we have roughly 10, 15 minutes left or so. What I'm going to do is just put this slide up while we're asking questions, because one of the things that we're always asked is, what's the best thing I can do to prepare myself for joint replacement surgery? And the answer is pretty simple, and you've heard a lot about this tonight. It's educate yourself. And there's a lot of misinformation out there. So I've just listed a few websites that you guys can jot down. One is our website, OrthoCarolina.com, has a lot of useful information about joint replacements. The OrthoCarolina Research.org website about research and joint replacements. The Arthritis Foundation has a phenomenal website on arthritis and management and treatment. And the American Academy of Orthopedic Surgeons has a patient portal on there that you can look at issues with joint replacement. So I'll leave those up while we continue to ask and answer questions. And
One more is aahks.org. aahks.org, American Association of Hip and Knee Surgeons.
aahks.org. Did you have a question? Go ahead.
Based on what I've learned at the seminar, if I could make a choice to have knee replacement, soon, I would. However, is there an advantage to my success if I wait longer and I have more damage to my joint, or if I don't wait longer and have less damage to my joint? Is there, because my lifestyle is limited by my pain and my limitations of activity. However, I can live with pain and I could probably wait longer, but I really don't want to. But is there an advantage to my success with the surgery if I wait longer or don't wait as long?
I can answer that. I think there's two issues that come up here. One is frustration, okay? And so most people kind of make the decision to have surgery when they've reached their frustration tipping point, okay? And that's individually based. The other issue that you bring up, though, is advantages to intervening early versus late. Across the board, if we look at your ability to put off a surgery and wait, the surgery doesn't change, okay? Your surgery would be today, tomorrow, same tomorrow as it would be probably 12 months from now. There is a few small studies that looked at what happens if you have surgery within 4 months of being diagnosed versus waiting more than 2 years. Those patients in each group, at the end of it all, equally satisfied with their outcome. So no difference if you ask them. From a functional standpoint, and Dr. Springer pointed this out, there is a subset of people in the group that waited more than 2 years that never reached the same level of function as the ones that intervene slightly earlier. Those are a unique subset of patients, and we can usually pick them up. It's very rare for us to encourage somebody to go on with surgery early. We tend to not push you to surgery. We tend to try to educate you and let you make your decision. The things that will, from my hands, push you to surgery or encourage you to surgery are when you start losing range of motion of the joint, okay, particularly in the knee, a flexion contracture where you can't straighten the knee, because that can prolong your recovery. And the other one would be when you start losing muscle mass around the joint. So if by not using the joint and protecting the joint because of pain, you start developing a significant amount of atrophy in the leg, whether it be the hip or the knee. In those instances, I will tell you, listen, you know, I think it's time. You should probably consider this sooner rather than later. But they're the only times that I would tell you that I would encourage you to go up in the short term and do the surgery.
But as a young patient, we're still going to encourage you to try to put it off if we can. We mentioned earlier, very good, very encouraging results of had patients under the age of 55. But we still see patients that have other health issues that we need to consider, obesity being one of those, which there's an opportunity to correct that. Or in those patients that are very, very young, when we know that the activity level for a young person is actually considerably greater than somebody 10 years and 20 years older.
That's where my frustration comes in, because as we travel and I exercise, daily, my frustration level is that I can't live the life I want to live right now.
Right. It's frustration, I think, is a big part of it.
I'd like to add something to the subject. To think about waiting is the risk of falling and you break the femur, or then it's harder when we have to do a repair job than do a replacement. Am I not?
We had a patient that I just looked after just a little while ago, a 90-year-old lady who is very disabled by the arthritis in her hip. Her highest risk is that not that she's going to have to need surgery for her hip, but that she's going to fall and have an unelective surgery.
There is an interesting study that was sponsored by the National Institute of Health, seeing what happened to people with bad arthritis who just didn't want to have surgery. Because we're all very attuned to the very real, if infrequent, risks of surgery. But what they found in that study was that people who had significant arthritis and didn't have it operated on had more depression, they fell and fractured their hip more often, they had more heart attacks, they died earlier by 1 year on average. And probably scariest for most people is they went into nursing homes at a lot earlier ages. So even though it's very logical to focus on the risks of surgery, there are well-documented risks of not having it if you have a bad joint now too.
Yeah, I just want to comment. I think one of the most important things, and you're all here today, which is great. You're here to learn about joint replacements. But let me tell you, the one thing that sometimes is overlooked more than anything else we do that can lead to less than satisfactory results is expectations. That you need to know what your expectations are after a joint replacement. You know, can I run and jump like I used to? Can I jog? Can I do a lot of these things? And I think it's important because everybody's a little different how they treat patients. I think if you know what your expectations are before the surgery, you're going to be extremely happy after the surgery. And so if you haven't talked to your physician about things, obviously it's very easy for us to say, you need a joint replacement, you should go have it done. But what if your expectations are different than mine? Then you're going to be disappointed. And I think it's so important to know what the expectations are after a joint replacement. And that's where your doctor should sit down and spend a good bit of time with you explaining your expectations.
Question?
Yeah, in your patients who had both knees replaced, I need both mine replaced, and they have one done, and they've recovered and they're back to normal activity, do they find that they can wait longer to have the other one done?
Yeah, absolutely. I
Very-
think
very
that,
often.
It goes both ways.
yeah, but you shift your weight over, you know, then you have a good leg to stand on, so to speak. You can take stress off the other leg. And sometimes you can prolong it for a long period of time, but,
The other side of that is your bad leg no longer slows you down, so you may become more active and realize your other leg's worse than you thought it was.
Is there a procedure now where, say for instance, if I had the knee replacement done and 15 or 20 years from now, I might need to have another, that they can just replace part versus having to replace the whole thing?
We do that a lot already. Yeah, so as I mentioned with the knee replacement, the polyethylene spacer in between is kind of like a brake pad.
Right.
And it's very similar to a brake pad in your car. If you get to it early, sometimes you can just take the polyethylene out and pop in a new piece of polyethylene. Did that just a couple hours ago.
Can you describe a typical rehab program after discharge from Mercy? What's it look like and how long?
Sure.
For knee
Tom,
replacement?
you want to field that question? Just discuss a little bit about the typical rehab protocol once you leave the hospital after a hip replacement? After a knee replacement, I'm sorry. Or both.
Like everything, it depends, and one of the things that it depends on is your home environment, meaning are you on one floor, are you on two floor? Do you have other things that limit your mobility other than the joint you had operated on? And who do you have to help you when you go home? One thing about the knee replacement is you don't really have to baby it. It's not like a hernia repair where there's a lot of don't do this and don't do that. And so you're encouraged to do as much as you can in terms of walking, bending, straightening it. And the therapist is there to make sure that you do more than you feel like doing. So you get therapy all the way along. You get it immediately in the hospital. Once you're discharged to the hospital, you either go home or in some cases you go to an inpatient rehab facility. And typical there would be if you live alone or if you have a lot of stairs or you have other joints that are slowing you back. Once you leave the rehab center, then typically the therapist comes to your house. A lot of people, after they finish a few weeks of at-home therapy, will then go to an outpatient therapy setting, and you keep up those exercises on your own until that 3 or 4 month time frame. So it's a long process. And it's not just about your knee. It's a big operation. You're going to have systemic effects from it. Most people lose weight. They don't sleep well for a while. Their appetite's depressed. So, you know, there's a little bit of an emotional roller coaster to it, too. Typically, pretty soon, though, it's obvious it was a good thing to do. And on that, when you're staging them, doing one and then the other, usually when people are back for that couple-month follow-up, they say, yeah, I really want to get the other one done, but, you know, no time soon, you know, which usually ends up being, you know, 9 to 12 months before they are willing to go through that whole process again.
Time for 2 more questions. So how does your bone density or osteoporosis affect your outcome after joint replacement? Even having it. Dr. Griffin, you want to?
Well, we deal with patients that have all different types of bone density, from the 40-year-old male athlete who has very strong bone to an 80-year-old patient with rheumatoid arthritis who may have very, very soft bone. So in most cases, it's not a factor. In the extremes, we may change what type of implant we use. In a hip, we might cement a stem in rather than using a cementless stem. So there are some modifications we might make in the extreme cases, but for most, women tend to be more osteoporotic than men in general, but we don't use different implants in that scenario. And it's just kind of part of what we deal with arthritis. If you have a joint you haven't been using very much, the bone tends to get a little bit softer, and so we're very accustomed to dealing with osteoporosis.
Is that determined before surgery?
It's just kind of expected, and you can tell from the x-rays to a certain degree, but that's, yeah, that doesn't influence how we do the surgery.
And it doesn't really affect your result either. I mean, osteoporosis is important because it increases your risk of fracture. And yes, sometimes you can have a fracture in surgery and you're more likely to have it if you have osteoporosis, and that can affect your result. But people who have osteoporosis do just as well with their joint replacements in general as people who don't.
Yeah, osteoporosis is a silent disease, and it stays silent until you break it, break a bone, and then you know you have it.
Okay, last question.
Okay, just when he was talking about just the therapy and everything, so I'm gonna take care of my mom while she's getting better and everything. As family supporting her when she's home, in addition to the therapist that comes over and the machine, what do I need to allow her to get away with, and what do I need to say, you know?
I'm gonna send her to a hotel.
What you need,
How mobile she needs to be, are there exercises that she needs to do outside of the therapist, and so I can, when she wants to lay up, I can tell her no, she needs to get up.
so, you mentioned earlier you're having a knee replacement. What your daughter's charge for you is gonna be to keep you doing things that you don't wanna do.
There's a
We
little,
already argue all the time.
there's a little whip that comes in the home package.
For her. But she should be able to get up and walk
Absolutely.
around.
So typically, patients are up walking the day after surgery,
Okay,
maybe 20 feet. Second day, they're walking 50 to 100 feet, maybe even climbing stairs on the second day.
no cane, nothing assisted?
No, they're using a walker or,
Okay.
yeah, so usually a walker, crutches for 2 or 3 weeks, cane for 2 or 3 weeks. But they're fairly mobile by the time they get home. They have to get in and out of bed, up to the bathroom by themselves, things like that.
Yeah, by and large, 3 things have to happen for you to go home. Number 1, you're in and out of bed by yourself. Number 2, you can walk up and down the hall. And number 3, you can do stairs. Those 3 things have to occur, and then you go home independent, and then it's safe.
Not by yourself, but
Real quick, last question right here.
Have any of you done surgery, knee replacement on someone that does not have a kneecap?
Oh, yes.
How
Bill, you want
successful?
to fill that question?
well, success is good. You can't replace the kneecap when you don't have one to start with. And when you lose a kneecap, you lose about 30% of your strength of your quadriceps, the big muscle in your thigh. And so you still have some residual weakness even after you do a knee replacement. There are some modifications in terms of the type of implant we use. We use what's called a posterior stabilized knee in patients that don't have a kneecap, just to add a little extra stability. But it's not as uncommon as you might think, and the success rate is good. You still have the weakness that you may have had beforehand.
Well, thank you all for coming. We hope to certainly do more of these throughout the year. And Blair's done a wonderful job. It's also available on the internet. And I think the replay of this will also be available on our website.
Yeah, we have the first seminar from October is already up on the website, and this one will be up in probably a couple of days.
And with every seminar, the questions are always a little bit different. There's a little bit of different information, so feel free to go to the website and look at the seminars.
We discussed risk a lot more at the last seminar. We really didn't touch on that this time, so.
Yes, exactly. Thank you all very much for coming.